This is the third part in the 4-part series looking at understanding the neurological examination. If you haven't seen part 1 and part 2, which are supposed to come before this session, I recommend you go back and look at part 1 and 2 so that this session makes sense to you. We will now go back to where we started from, talking about the steps in a neurological examination. And if you remember, I said in this session we're going to focus on the tone, power, reflexes, and sensation, and seeing how those correlate with the neuroanatomy. And I'm now going to start going through each of those steps in detail. We start by looking at tone, and we will start with our illustration, which has been present throughout this session. So tone is moderated by the nervous system, both the central nervous system and the peripheral nervous system. So it's here, the central nervous system, the brain, and the spinal cord, and then again outside the spinal cord. So if there's a lesion that's anywhere between the spinal cord and the brain, an upper motor neuron lesion, like we said, that is going to manifest with increased tone. If you have a lesion that's occurring outside the spinal cord in the peripheral nervous system, that lesion, like we said, is going to be called a lower motor neuron lesion, and it's going to manifest with decreased tone. So it's quite straightforward in terms of what problems you will see with tone and how to correlate them with the structure of the nervous system. We move on to power. I've got the diagram back, and I like to think of power as being tested through limb movement, because that's what we'll ask the patient to do. So we test how strong their different muscles are by asking them to do particular movements. And you see I've put those words move in red, and really movement is also motion. And I highlighted this because it's easy to remember the parts of the nervous system that are involved. So that starts with the motor cortex, which is responsible for initiating movement. And then you have the cortical spinal tract that we talked about earlier. And then outside the spinal cord, you have the different nerve roots that are going to carry information that's coming from the motor cortex down into the spinal cord, into the organ. I'm just going to draw in these areas. So starting with the nerve root, and then your corticospinal tract, and that's it there going up to the cortex. So for you to have a problem with movement or a weak limb, you have had a lesion somewhere in the course of this line. So it could be a lesion in the cortex, or like a stroke, that's going to affect one side of the body and you're not going to be able to move, or that side of the body is going to become weak. Or it could be anywhere in the corticospinal tract, and it could also be a problem that's in the periphery, affecting a particular nerve root that's going to cause reduction in power or failure to move a particular limb. We move on to deep tendon reflexes. So I've used the knee to illustrate this, but we could have said the same about any of the other tendon reflexes. So like the biceps or triceps reflexes, the mechanism is the same. So tendon reflexes have to go through the spinal cord, and this is a stretch reflex. So you tap the tendon or the end of the tendon with a hammer to stretch it, and that triggers a reflex that travels into the spinal cord, and the neuron that carries the information from your limb into the spinal cord is a sensory neuron. Or in some books you'll see they'll talk about an afferent neuron, but it's just moving sensory information from the peripheries or from the limbs into the spinal cord. And once that information gets into the spinal cord, another neuron carries the information back into the limb, in this case back into the knee. And what that neuron carries it's a motor neuron. Okay, so remember, motor, we said this has to do with movement. And if you stimulate this reflex, it's going to take a few milliseconds to run through the whole arc, and stretching that will cause you to extend at the knee joint. So this leg is going to move that way. So just to emphasize again here, the key part is the spinal cord, because that's where the neurons get to talk, and that's where the information gets to travel back into the limb. So going back to this diagram, so if you see this would be coming from the peripheral nervous system into the spinal cord, which is your central nervous system. So this part needs to be intact for you to have normal reflex, but also this part in your central nervous system also has to be intact. And you can get lesions in that part or in this part of the nervous system. So if you get a lesion in the lower motor neuron, which is outside the spinal cord, that will result in reduced or absent reflexes. If you get a lesion in the central nervous system, in the cord or in the brain, that will result in an upper motor neuron lesion, and when you check the reflexes, you'll find brisk or increased reflexes. Sensation has several modalities that we test for, starting with light touch, pinprick or pain, temperature, proprioception or joint position sense, and vibration. And I'm going to work through each one of those to show you which part of your nervous system is responsible for carrying that function. So back to our illustration. So the first tract that I want to talk about here is the spinothalamic tract. So it carries sensory information from the peripheries into the spinal cord and up to the thalamus. So this tract carries two sensory modalities, which are pain and temperature. So when you're examining a patient and you're testing for pain or testing for temperature, you're actually testing for the integrity of the spinothalamic tract. There's another tract that's very important for carrying sensory information, and that is your dorsal column. So your dorsal column carries information from the limbs or the peripheries up into the spinal cord into the brain. And the modalities of sensation that it carries are proprioception and vibration. So when you're testing a patient for proprioception or vibration, what you're actually testing is the dorsal column. So if you look at the modalities that we've covered so far with this tract, we've covered pain or pinprick, we've covered temperature, proprioception, and vibration. That leaves one sensory modality, which is light touch. So light touch is a bit different because it has some fibers that are carried in the spinothalamic tract and other fibers that are carried in the dorsal column. So that makes it a bit non-specific, and if you see these tracts, you see they're only carrying these specific functions, and you can easily tie them to each one of these tracts. But light touch actually has got one bit traveling in the dorsal column and another bit traveling in the spinothalamic tract.